Yeah.
All right, good morning. I will share my slides. Then disappear. Okay, is that visible? That's still in the way.
I see the black box at the bottom. Yep.
Is that good
And
now?
there's one more under recovery. There we go.
Okay, all right, thanks. Hello, my name is Mari Hodges, and I'm a therapeutic pain specialist and a teacher of Alexander technique. I'm also a person with a lived experience of persistent pain. I hold a master's in science and medicine and pain management, and I'm really excited to be here to tell you about pain and pain recovery founded in modern pain science, and also talk about this new free community program called PainSavvy Walk Talk. I like to start any talk about pain by saying that all pain is real. And often the message that pain is in your head can come across very easily. But it's important to know that there is hope for recovery, and that's supported by modern pain science. And it often means something other than medications and medical interventions and surgeries. So today I'm going to talk about persistent pain as a public health issue and the current scientific understanding of pain, some more useful ways of thinking about and addressing pain, and how we do that on both an individual and a societal level. There's an increasing population in pain. Almost a quarter of Americans experience persistent pain. And pain is the main reason for seeking medical care. Persistent pain is a massive problem, and the incidence is high compared to other quantified chronic diseases and conditions, such as diabetes, depression, and hypertension. Chronic pain is the leading cause of disability, and some of those top causes of disability are back pain, chronic back pain, neck pain, osteoarthritis pain, and other musculoskeletal disorders. Pain takes an enormous toll on individuals and families, and the societal economic cost of pain is comparable to that of other more well-known conditions, such as heart disease and cancer. And the burden of persistent pain is expected to continue to rise with Americans' aging population and increases in obesity and inactivity. So who gets pain? Pain is more prevalent among American Native adults and adults who are divorced, who are living in poverty or near poverty, without a home, who have a lower education level, who are older, who live in rural areas, who are unemployed, and who are women. So we can see that Montana is at a high risk of individuals with persistent pain. And here we can see graphically some of the differences in the prevalence of persistent pain among different ethnicities. And we can see that the American Native and Alaska Native adults are at the highest risk of persistent pain. Persistent pain is a health equity issue. Anyone can get persistent pain, but where you live does impact pain. And persistent pain disproportionately impacts marginalized and disadvantaged communities, including rural communities. And living in a disadvantaged and a disinvested neighborhood alters stress system function, increasing allostatic load and putting individuals at a higher risk of more pain and increased disability long-term after a traumatic event, such as a motor vehicle accident. Here are some examples of some Montana data. And Montana adults consistently have a higher prevalence of osteoarthritis pain, pain greater than the average for the nation. And while Native American and Alaska Native adults don't have a higher prevalence than the general Montana population, they do experience greater impact on activity and greater pain severity. Not enough research has been done on the relationship between pain and racism. It is known, though, that people of ethnic and racial minorities are less likely to receive effective pain treatment. Racism and discrimination have significant biological and psychological consequences. And research is beginning to put some light on how systemic racism impacts pain. One way this may affect individuals is a coping strategy of stoicism. So individuals may not even go for healthcare, and so they may not even show up in the data. Socioeconomic factors of patients are highly associated with not receiving effective pain treatment for severe pain conditions, as are provider attitudes and unconscious biases. But what we're doing isn't working. Imaging, surgeries, medications, nerve ablations, injections, and other passive therapies are widely used, frequently in source of an elusive biological origin to pain. But excessive rest and passive coping lead to poor outcomes. Telling people to stretch and to exercise doesn't work because many people don't want to exercise precisely because it hurts when they move. Some exercise recommendations, such as core tightening, can actually contribute to back pain. And medications often have harmful effects. Opioids, for example, can be useful for some people in some situations, but they not only promote dependence, they can also lead to increased pain in a condition known as opioid-induced hyperalgesia. And as a standalone treatment, a one-size-fits-all passive therapy approach is likely to have no effectiveness over any other intervention, except for short-term relief. And while passive therapies can provide short-term relief, in many cases, these interventions lack evidence of effectiveness, and they're accompanied by risks and adverse effects that often outweigh their benefits. They tend to promote increased healthcare utilization, and they're associated with poor outcomes. So conservative treatment and medical interventions have failed to resolve the pain problem. They're just not that efficacious in and of themselves. Here are some examples showing that lack of effectiveness of some typical medical practices for pain. Inappropriate spine imaging leads to increased back pain, unnecessary surgeries, and increased healthcare costs. And while surgery can be extremely effective in some cases, surgery for lumbar disc herniation provides no benefit over conservative treatment, which we saw is ineffective in many cases. And after lumbar spinal fusion, 35% of patients continue to use opioids long-term. And after total knee replacement, 20% of people continue to have chronic knee pain. And this tells us that pain is about something more than just the joint. So why aren't these conventional therapies working? Many of them are based on assumptions that the problem is in the tissues, in the joint, for example, and that pain is an accurate indicator of the state of the tissues, and that resolving the underlying pathology will resolve the pain problem. And it's actually not quite so straightforward as that. This biomedical view is now known to be overly simplistic and limited in its usefulness for understanding and addressing pain. And to understand why they're not working, we need to have a good understanding of what pain is and how it works. Modern science shows us that there is a weak relationship between pain and tissue damage. That pain is not an accurate indicator of what's going on in the tissues. And that medical and pharmacological interventions alone don't work. And that we need different approaches to resolving persistent pain. And so it's important to understand what pain is, and to understand that, it helps to understand what pain isn't. What pain is not is tissue damage. Pain and tissue damage are not the same thing. I wonder if anyone has heard of the story of the hiker who got his hand caught and he ended up cutting off his own hand to survive. And when he did that, in that moment, he actually felt euphoria.
Is that the one that, Mari, is that the one that became a movie?
It did, yes.
Okay.
Yeah, it's a true story. And that gives us some information about how pain and tissue damage are not the same thing. And has anyone ever gotten up during the night to go to the bathroom in the dark and stub their toe, and it hurts like the dickens, and then nothing really happened to your toe? So these examples illustrate how there's rarely a one-to-one relationship between pain and tissue damage. And when pain persists, this relationship becomes more tenuous. In some conditions like chronic back pain, neck pain, fibromyalgia, chronic regional pain syndrome, severe pain may occur with no identifiable tissue damage. Here on the left in this image, you can see a pain-free individual with a disc herniation. So we can see that disc herniations are not necessarily correlated with pain. And on the right, you can see some images of some real cases involving nails through a boot and into the jaw, and some unexpected pain experiences that I won't go into today, but those are very well-known cases that do not turn out quite how we expect in regard to pain. Here are some more examples of asymptomatic abnormalities reflecting that lack of relationship between pain and tissue damage. Disc degeneration, disc bulges, herniation, osteoarthritis, rotator cuff tears, and knee meniscus tears are extremely common in people with no pain. And we know that pain can exist without injury, and we can injure ourselves and not feel any pain. And it boils down to the fact that pain is not a marker of structural pathology. And these statistics tell us that pain has to do with something more than tissue damage, that tissue damage doesn't tell us the whole story. Sometimes we do see a co-occurrence of structural abnormalities and pain. And when that happens, we're fine with it, as in the happy face emoji in the top left corner of this graphic created by Dr. Stephen George of Duke University. But when those two things don't align, people experiencing pain get all kinds of reactions, as in the top right corner, reactions such as disbelief, humiliation, and invalidation of their pain. And that often leads to stigma for people, stigma experienced by people living with persistent pain. So what is pain? Pain is a protective response of a pain system to actual or potential damage. So it's meant to keep us from harm. An example of that is if you've ever touched a hot burner and pulled your hand away, you likely pulled it away before any damage was done to your skin. So pain motivates us to pull our hand away before we're even damaged. Pain protects us from injury. It's like the proximity sensor on a car that's backing up and it beeps as you approach the pole. It's going beep, 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 beep to tell you that you are in a dangerous situation. If we ignore that beeping, if we ignore pain, we may do some damage. And when we do injure ourselves, the pain system provides extra protection with extra sensitivity. A good example of this is a sunburn. If you've ever gotten a sunburn, even light touch or your regular shower can be painful, despite lack of harm. It's not harming us. And that hypersensitivity actually promotes healing, because now even minor things hurt. So we tend to protect ourselves. And this hypersensitivity usually goes back to a normal level as healing occurs. But sometimes, and in some people, this hypersensitivity persists longer than expected, and even after tissues have healed. Hypersensitivity manifests as increased sensitivity to noxious stimuli, known as hyperalgesia, and pain evoked by non-noxious stimuli, things that normally shouldn't hurt, and that's known as allodynia. And pain system hypersensitivity actually keeps us from doing things that would make us better. It's overly protective. It's like that car with the proximity sensor beeping often and early, even though we're not too close to the pole. So that's an overly protective response of a sensitized system. It's not accurately telling about danger. And in persistent pain, sustained changes can occur throughout the nervous system on multiple levels. And that happens even when there's no tissue damage. And those changes in the nervous system worsen over time. The longer that you have pain, the more sensitized the system becomes. And so how do you know if you have a hypersensitive pain system? Well, pain tends to be disproportionate to an injury. There's usually many sites of pain throughout the body. There's often sleep, mood, and cognitive problems, fatigue. And there's an altered sense of the body and of movement. And medications don't tend to help much. Chronic pain can actually become a disease in itself. And the new International Classification of Diseases now includes chronic pain as a disease in its own right. One of the key features of persistent pain is neuroplasticity, or prolonged changes in the nervous system on multiple levels, such that information sent to the brain is amplified, heightening pain perception. And plasticity profoundly alters sensitivity, and it can become a major driver of pain. So here we can see an impulse coming from a stimulus, information about a stimulus, and amplified information going up to the brain. The many changes that occur in the brain in persistent pain are examples of this kind of neuroplasticity, and that also impacts the experience of pain. But neuroplasticity also means that pain can change, and that gives us hope and potential targets. And the ability of the nervous system, including the brain, to adapt and to change is an important part of rehabilitation and recovery. So the message is that the pain system can become hypersensitive, but over time and with work and with patients, that can be reduced back to a more normal level. But to do this, we must address the whole person. So how do we do that? To address the whole person, we can first validate a person's pain. We can reframe how we think about it. We can increase movement, make changes to lifestyle factors, address stress and mental health, and put the individual in charge of their own pain management. So first of all, it's so important to believe what a person says about their pain, as many people experience invalidation of their pain, and that can make it worse. An important first step in recovery is reconceptualizing pain. And so for that reason, it's important to get accurate information out to the people who need it. And here's an example of this for back pain. And changes in the back, we can think of as wrinkles on the inside. They're a normal age-related process. And there are weak relationships. There's a very weak relationship between back pain and structural changes in the back. A lot of people without pain have disc degeneration. That happens to all of us as a normal aging process. Many people have disc bulges with no pain. So it doesn't mean that physical pathology isn't important, but it does suggest that other variables are important and worthy of our attention. We can help people to understand pain as threat assessment, their nervous system assessing threat, risk, and protection from threat. The nervous system is always assessing threat versus safety. And that's based on all the information at hand, not just information from the body. But sometimes, and for some people, that threat assessment gets stuck in the red, resulting in an overly protective, persistent pain experience. And that threat assessment takes many factors into consideration, not just information from the body, including it, but other factors as well. And here are some examples of factors that can contribute to driving pain or reducing it. So pain system sensitivity changes depending on what's going on in your life or what has gone on in your life in the past. Healthcare professionals have a profound impact on individuals' beliefs and behaviors. And beliefs and fears about damage, about the need for rest, about not moving, those kinds of beliefs are passed on to patients. And that can result in poor outcomes because of overprotection. So we can reflect on whether we're reinforcing harmful beliefs or promoting self-efficacy and the ability to engage in valued activities with our own attitudes and actions and words. And we can encourage patients to adopt an attitude of teach me how to recover, as opposed to give me something to relieve my pain. There, the X hadn't shown up. So this stop as it hurts is now X'd out, as that's generally an inappropriate strategy for persistent pain. So this requires a shift in our language, because language has a profound effect on our beliefs and our experiences. So here are some examples of some language that can promote a sense of threat, such as phrases like bone on bone, which is an inaccurate conception of osteoarthritis, to those promoting resilience and health and improvement, such as knees need to move to be healthy. It also means a shift in messaging from reinforcing beliefs about the body's vulnerability and need to protect to the body as resilient, and giving permission to get on with life without waiting for pain to reduce. So some examples are of threat-provoking phrases would be use pain as your guide, or it's old age and you'll eventually have to replace that joint. And instead, we can encourage people with thoughts like learn to listen mindfully and gradually increase movement. There's a lot you can do to reduce pain and stay healthy and active. So how do we get people to move when they hurt? It's important to help people to understand that hurt does not equal harm. And any kind of movement is good to do. In fact, the best kind of movement for any individual is the activity that's important to them. The challenge is to get the right amount of movement to create an adaptation in that pain system to reduce the hypersensitivity and to increase fitness without causing a flare-up. So that understanding and working with someone that's trusted is important. It's important to work with someone who's actually trained in pain science, who can help a person to understand that it's okay and even important to move, even when there's some pain. And it takes time and patience and training to reduce that nervous system sensitivity. But there are a lot of ways to retrain our nervous system. And here are some examples of some approaches: pacing and different ways of exploring safe movement, including mind-body approaches. Sensory motor retraining is another way that is showing effectiveness for getting people back to feeling safe to move so they can get back to life. So this means a shift in focus from focusing on reducing pain to improving function, because focusing on improving function leads to more improvements, like improvements in daily activities and mood, self-efficacy, catastrophizing, and also the added benefit of reduced pain. We also need to promote healthy lifestyle habits, as sleep and diet can have a large impact on pain. We need to help people deal with stressors and mental health challenges, because stress exacerbates pain, and many mental health conditions such as PTSD, anxiety, and depression have a relationship of mutually impacting each other with pain. So this means a shift in perspective as well, from one of fixing the patient, fixing the body part, to accompanying the individual on a journey in which the individual is in charge, not a helpless passenger. And self-management doesn't mean throwing people to the wolves, doesn't mean being thrown to the wolves. Individuals may need help retraining their pain system. And that help can come from a pain coach, a therapist, peer support, and other types of support. Individuals may need help to understand their condition and to encourage changes in lifestyle behaviors. And people want to know, what can I do? What can I do for it? And there's so much that people can do. And here are some examples of the many things that people can do to help reduce the sensitivity of the pain system. And because pain is always an experience of an individual in relationship to their environment, and that includes other people, organizations, things going on, the surroundings, context shapes our experience, and it shapes pain experience. So it's important to consider social factors as well. And this is often a part that's left out. In fact, musculoskeletal pain is associated with loneliness and perceived lack of social support. Social prescription is something that's going on in some countries to connect individuals with community resources. And that's showing great promise. And I want to tell you a little bit about one example of a community resource, which I have developed and I'm running. That's called PainSavvy Walk and Talk. And this is a free community program. Everyone's welcome to it. People with pain or without pain, people caring for someone with pain. It's open to everyone. And the program is based on some of the pillars of increased resilience and improvement and reduce pain. And those include learning about pain, learning about the foundation for engagement in activity. And that helps encourage people to want to engage in it. If you don't have an understanding of how pain works, then it makes sense that you wouldn't want to do activity. And that understanding helps people to engage in activity and other healthcare treatments like physical therapy. So one of the pillars is learning, another is graded activity, gradual physical activity, and positive social interaction. And the talks in this program they introduce people to the science of pain and pain recovery to support that engagement with evidence-based approaches. And the topics, the talks feature topics like general chronic pain, back pain, neck pain, osteoarthritis pain, fibromyalgia. And that's followed by a walk, which is optional. People can walk as much or as little as they want. And they can enjoy a chat with others as they're walking. And this program has just moved to the Missoula Public Library as part of their health literacy program. And it's on the 2nd and 4th Sundays at 1 p.m. So here are the upcoming dates this year. This coming Sunday, the 22nd, October 13th, November 10th, and November 24th for the rest of 2024. And you can learn more about the program at discoveries.how/PainSavvy-Walk-Talk. And I invite and encourage you all to join us there.